प्रणाम सर। आवाज आ रही है सर मेरी?
बिल्कुल आ रही है, बिल्कुल आ रही है आवाज। और कैसे हैं आप?
बिल्कुल ठीक है सर। आप
बढ़िया है।
ठीक?
हम्म।
आई एम फीलिंग प्लेजर टू सी यू ऑन द स्क्रीन।
अरे आनंद, डॉक्टर तिवारी आएंगे क्या? हेलो
सर
आनंद,
बात कर लेते हैं उनसे।
बात कर लीजिए, 2 मिनट के लिए आए।
जी जी।
सीनियर आदमी हम लोग को, हम लोग के बीच आए हैं तो भाई बुला लीजिए। 2 मिनट के लिए सर को बुला लीजिए।
डॉक्टर कमलेश तिवारी सर आ गए क्या?
नहीं, देखते हैं, कोशिश करते हैं, उनको खाली होंगे तो आ जाएंगे।
सर 2 मिनट में ज्वाइन कर रहे हैं।
अच्छा, कर रहे हैं। वाह,
जी जी, 2 मिनट में ज्वाइन कर रहे हैं।
वेरी गुड, वेरी गुड।
प्रणाम सर को प्रणाम।
प्रणाम 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 प्रणाम।
सर, गुड इवनिंग सर।
गुड इवनिंग, गुड इवनिंग। वेल
सर,
डन, वेल डन, डूइंग वेरी वेल।
सर आप हैं जहाँ
हाँ जहाँ बाहर है
मुमकिन
सर।
है। और कैसे हैं सर?
ठीक है, ठीक है, ठीक।
हम्म।
दो दो झंझट झेल रहे हैं।
हम्म,
No, it's nice and it is going very well.
जी
I
सर।
think it should start now. Dr. Ajay Sinha is here.
सर,
He will guide you and start the session. Dr. Ajay, please.
sir, this is my great pleasure to have you back on the stage because Dr. Tiwari was not there the last few meetings. So उनका थोड़ा हम लोग को blessings and drive मिल जाता है, तो then we go ahead. So this has been a great endeavor of Dr. Kamlesh Tiwari, Professor Kamlesh Tiwari, who started this project, I think very unique. And this has not been there across the world, I would say. Even the best people like grand round from various places, they are not so frequent. We have every Friday, we have ragging going on. Ragging for us also, because we have to find out the person, correct person. So thank you very much, sir. And thank you. Let me thank all the top brasses of API, blessings of Professor B.B. Thakur, and all those great people like Jyotirmay Pal and all those senior people. So let me introduce Dr. Khetan. He is a man who is son of a soil. Because we have several times we have seen him performing at Gaya, dancing on the stage. धीरे धीरे सर का दायरा बढ़ता गया. Now, several times I have told that the way he is putting everything in his that perspective, that ECG has become his ECG is synonymous with Dr. Khetan. And I'm sure one day we'll have his name all over the world. Of course, yes. So with this background, with the permission of Professor Tiwari, I invite you, sir, to start on this topic, which seems to be very simple, but very tricky. So over to you, sir.
Thank you, sir. Thanks a lot. Respected Dr. Kamlesh Tiwari, sir, Dr. Jatinder Pal, President API, Dr. Gigesh Mathur, Dean-elect ICP, Dr. Agam Mora, Honorary General Secretary API. And equally, salutation with thanks to Dr. Ajay Kumar Sinha, who is the course director here, and all my students. Though of course, as introduced by Dr. Ajay Kumar Sinha, the topic seems to be simple as line, but it is having some sort of intricacy inside. So my topic is today of his VT analysis on ECG bed simple. It is more or less not accurately so, but it is more or less like Hiran or Kachwe ki chal ki daur competition. So we may say that the ventricular tachycardia is having a rapid, usually more than 100 BPM, independent itself by itself, having wide QRS. It is driven by the ventricles being the site of the pacemaking here. Number 1 point. Number 2, the QRS is wide enough because it is muscle to muscle transmission, not from Purkinje fiber from above to downwards. So muscle to muscle transmission takes some time. So that's why it is more than 120 milliseconds in duration, and also bizarre in morphology because the site of the genesis is not different from that of the original one. The atria and ventricles, they are dissociated from each other. Atria, they beat independently from its own beat, and the ventricles beat its own by its own beats. That's known as the AV dissociation. There is no fixed relationship. Sometimes the P comes over the T wave, sometimes before the T wave, sometimes after T wave, and so on. Mechanism being re-entry, Tiger activity, or enhanced automaticity. I shall bring all the terms at the end, how the mechanism get operated. With these words, I would like to let you know, already you know, I think so, how to identify the P waves, which is the symbol or the sign of the AV dissociation. So here the P waves marching through their own regular rate, say 160 to 100 BPM, even though the QRS is wide and fast, no fixed relationship is there. No fixed relationship is there. Check the inferior leads for the purpose, because inferior leads passes through this axis of the passes through their inferior leads. So the most likely is the site of the most visible site is the inferior leads, especially lead 2, and also V1, because V1 lies over the nearby the right atrium. So V1 was the way. So check inferior leads 2, 3 AVF and lead V1 where the P wave was most stand out most visibly or the most best. I want to mention here the haystack principles of Marriott. If you have lost some pin over the bigger haystack, it will be difficult to pick it out. But if you try to pick it out, if it is down to the smaller haystack, it will be easier to pick it out. So choose the smallest lead having the smallest sort of the QRS and T complex. That's why, so that the P wave may be picked very easily. In direct evidence would be the capture of the infusion beats. Even sometimes the group beating or the occasional slight cycle length changes can hint the atrial process. How? I shall be mostly by the next slide. You'll see the first ECG tracing is showing the beating of the P wave indicated by the arrow. The P waves are seen sometimes after the T wave, sometimes initial at the initial of the P wave. So this is the dissociation. It has no fixed relationship. So B, P, and QR, means atrial and ventricular, they are dissociated in DT, having no fixed relationship. The falling of the P may be different at different sites. You have to see very carefully. Occasionally, a slight cycle length is indicated here by the cycle P wave below. It is somewhat having somewhat lesser more duration. It is occasionally is not always seen. Red mark is given of that part. So occasionally a slight cycle length change can hint at atrial influence. And capture beat a fusion beats out since the both are beating independently of each other, atria and the ventricle, but sometimes the atrial beat may be caught or captured by the ventricle, what we call the capture beat. Here you see that in the diagram, you see in the diagram, the capture beat is just the like the here just like the this red labeled horizontally is the capture beat, just like looking the normal normal QRS complex, PQRS complex. That's why it is the indirect evidence of the that we have seen the capture beat in the form of this P instead of P directly. Sometimes this capture beat may be combined together with the so-called ventricular beat to give actually some sort of intermediate shape. And this intermediate shape is known as the fusion beat. So the convergence of the capture beat or the fusion beat or the both or individual is the indirect evidence of the P in AV dissociation. What I am to carry. This is a very important part to be understood. There are so many criteria. I do admit there are so many criteria for the AT identification, this atrial, this ventricular identification, but the most important are two: Verigi criteria and the Brugada criteria. Unless until we don't understand the basic mechanism behind that, we can't apply the criteria with more accuracy. That's why here I have kept this slide for that purpose only. This Verigi criteria, that means is being formed around this, say around the scar formation. Scar formation is having three-part components. One is the component is going away from the initial site of the AVR, that is initially of the AVR on the vertical plane, and this down going away from the means we describe the negative wave. It is the rule of 90 degree. Any lead which is going away from the sporting electrode, we report the negative wave. Otherwise, it will be recorded the positive waves. That's why the initial component is going away from the site of the observation AVR here. That's why the small broad negative deflections there. But the pathway, this circumscribed pathway, somewhat scared pathway, somewhat deformed pathway, that's why it is having sort of fragmentation. The conduction is defect. So this conduction may inscribe RS small r oblique s capital instead of the initial Q wave. So initial Q wave either or the RS wave may be observed as initial deflection by this sort of mechanism. So we can say the initial VI, VI means initial, V means voltage. This initial voltage is a small broad negative complex deflection upward of course due to fragmentation conduction. When the after circumscribing this pathway, if it goes towards the AVR lead, that means towards the lead of this portion, the pathway with the positive higher amplitudes. Why higher amplitude? Because it is the pathway where we may meet with the either the faster Purkinje pathway adjoined with the, some sort of the myocardial therein. That's why we may see the somewhat more augmented amplitude. So there is a higher amplitude with positive wave function compared to the VI. That's why it is known as the VT. It is known as the V terminal, voltage terminal. So these are the basic things. So we can see that by high-looking bird's eye view over the vertical plane with more coverage is there, AVR captures initial, middle, and the terminal conduction. Initial conduction means slow conduction, muscle to muscle conduction, or conduction through somewhat scarred myocardium. It is going to initiate the VI initial voltage complex, which is slower and somewhat with lesser amplitude. Middle is the dominant wave. Every part, whether it is the vertical plane or the original plane, there is dominancy of the wave through which we see. Here, the dominancy in the form the R wave. Let's say R wave being positive here. So dominant R wave is being picked up by the AVR lead. Terminal pathway already spent there is possibly faster Purkinje or plus minus combined with the myocardial wave front. That's why it is forming the somewhat smart pathway, smart uplift. That is the some sort of the greater amplitude of the amplitude of the later part of the voltage. That's why Verigi criteria is a precious tool. It is a very precious tool. Why I shall explain later on. Sensitive to subtle vertical shift. All the components of this part means initial VI, VT, and the dominant. Dominant would be observed, no doubt, because it is dominant. Other was the sometimes the initial path may be missing, the terminal pathway may be missing, or both may be absent. So all the components of this pathway may not be observed in the AVR. That's why it is some sort of having some sort of lacunae itself. It is having some sort of lacunae, but how to see that sort of lacunae or the true observation or the Verkey pathway? The next slide is there. You should remember the R dash small r oblique q, n, and v as a mnemonic. R means R wave being dominant, initial dominant R wave. Initial dominant R wave because it is visible, it is always present, it is not the absent there. That's why is the point is step one. If you see the R wave there, irrespective of the axis deviation or the axis formation, any positive deflection step suggests. If you see the R wave, you may step, you may stop yourself here, saying that I'm dealing with the VT. But if it is not being so conspicuous or having some sort of a confusion in mind by the seeing that I am seeing this R wave because it is being seen in the extreme right axis deviation near about 180. So you may proceed to the next pathway, initial R or Q wave pathway. Here I want to say that the Purkinje transmission conduction is very rapid conduction. In normal conditions, it is up to the 0.4, that is 40 milliseconds, up to 40 milliseconds. In any, if it is more than that thing, it means the Purkinje pathway is not involved in the transmission, in the conduction pathway. So it is a muscular to muscular, muscle to muscle transmission. So this sort of the things, initial R or Q wave, indicates that the muscle to muscle transmission is taking place, and the initial R or the Q wave is taking place here due to the initial voltage deflection. It is time related. It is time related. It is not the amplitude related. It is time related. So step 2 is there. The below is this deflection, negative deflection is there because I have already said the initial is that is negative away from the point of the AVR, and the width is saying that it is more than 1 small square. More than 1 small square means it is more than 40 milliseconds because 1 square is confined to the 0.04 or the 40 milliseconds like that. The next, if it is not being observed already, I have dictated that any component may be absent except the initial dominant component. If that component is not clear, you may see any downward stroke of the negative device, any nose down stroke. Why there is no down stroke? If I am sitting here, I am an old person. If I say turn backward, I may fall down. It is normal tendency. This wave is not away from the normal tendency inscription. That's why the down stroke, we better to understand that when is the up stroke, the down stroke is formed is negated by some sort of the sudden change of the direction. This sudden change of direction may be inscribed by the presence of this Q wave. This I mean the down stroke of notching over the negative QS complex. It's very high. It may be the proximal part. It may be the nadir part. It may be the next to the nadir part. So this surrounding the nadir part, maybe sort of the tip of the RS wave, you may find the nose downward stroke. But anyway, it may be formed even the proximal, somewhat proximal as well. So it depends on how much amount of the quantum of the turning back about doing the transmission of the back is in place. The next, if it is not being seen there, the next proceed to the next. If it is seen, it's okay. It is a VT. Because any positive sequential step suggests VT. If not seen there, then due to the ratio of the VI initial and VT, then ratio of the VI initial and the rate of the VI terminal. I already told that the VI is taking the upward more quickly. It is a more sharper wave. So amplitude will definitely will be more. If more amplitude, that means compared to the VI, that means less than 1. The ratio will be less than 1. Anyhow, even if it is of equal amplitude, the ratio will be equivalent to the 1. In either condition, it suggests that the condition is of VT origin. So in that way, this vertical pathway of Verkey helps. If we understand the initial conceptual concept, there is no doubt we are going to catch it very easily over this Verkey pathway. I am dealing with all my conceptual because I am ultimately going to form a master chart. How to identify the master chart may be placed over the table of the clinical clinicians or by the table of the studying PG students or students. By seeing the charts and by ticking that this thing present, or the vertical, this thing present, or the horizontal, This much the things there. So unless until we don't understand the basic concept herein, we can't do that. We can't do the justice. That's why I am dealing with so much of the delicacy here. Why about the horizontal? All of you know that the horizontal pathway is somewhat different from that of the vertical pathway. In what sense? We place the V1 to V6, no doubt. And these V1 will vary either V1 or V2 or V3 or V and so on, only inscribes the dictated pathway underneath the myocardium in relation with the quantum of the electrical axis, in relation with the quantum of the electrical axis. So it picks up the pathway changes below this myocardium, just below the chest walls. So below the chest walls with horizontal means you may see either the wave going upwards in inferior, superior to inferior, or front to backwards, like that, or somewhat in every direction, better to say. So initial pathway, initial reflection, Vi or Vt, they are cancelled here. That's why it is not being these either the Vi or the Vt are being not observed at all in case of the horizontal transmission. That's very important to understood. So dominant horizontal diffraction comes from the main bulk depolarizing wave. There is the middle part, and there is a middle part of the either the R wave of the RS combination, not from the starting or the ending activation process. So we can say the horizontal transmission flow with restricted coverage here in comparison to the Vedic criteria. So focus is mainly on the dominant depolarizing wave, muscle to muscle transconduction. That's why. And fine initial transmission reflections are nullified. This pathway, this sort of the conception is very much the foundation of the understanding of the Brugada criteria. What I think. I have worked in this forming this concept. I worked for 2 or 3 days continuity. How to understand this concept with very clarity, so that I formed these slides. This of the slides. Nowhere in the book this has been mentioned. Nowhere in the book this has been mentioned. Now come the Brugada criteria originally. Step 1, RS. What is mean by the RS? If you remember the first class of mine, where I have declared that there is a progression of the V1 from the V1 to V6. V1 is small r, but by it is deep, then towards the heavier or the heavier level, which we saw the more prominency of the R wave and the less quantum of the Q wave initially, and the transition phase in between what you call the RS ratio equivalent. You see in the case of normal transmission, but yes, transmission is not normal. It is muscle to muscle transmission. So there is no question of inscription of the RS wave. So if RS wave may be formed in any of the leads in VT, but when they are completely absent throughout, it is very much suggestive of the VT. It is very much of suggestive of the VT. That's why absence of RS complex in all the periods is very much suggestive of the VT. Yes, okay, otherwise not so. SVT, otherwise SVT. And the width is very important. We can say that the width is more than 120. It's very easy to say. But by accuracy, say in the Variki criteria, we measure the initial R or the S being more than 40 milliseconds. Here we we measure the tip of the R wave, and also the tip of the S wave. And this difference measures this major difference is reflected in the form of the width actually taking place. If it is more than 100 milliseconds in one picotal lead, this criteria is set to positive, otherwise not. Next proceed. Main QRS complexes, more QRS complexes compared to V, because the rate of the ventricles beating is more compared to the rate of the atrial beating. So number of the QRS complexes would be more. What we call the AV distribution. This AV distribution may be encountered by different process, either by counting the P process. It is very difficult because sometimes the maximum of the P numbers are buried inside the graveyard of the QRS complexes. So they may be difficult. Only in 20% of cases, better to say, the P might be observed therein. So it is very difficult. We may draw the conclusion by seeing the capture beat or the fusion beat or somewhat cycling bigger cycling of the RI intervals. That way we can show these things. So AV distribution is very important part of this sort of the Brugada criteria. And what is morphological criteria? Morphology is very different. In last Vergi criteria, morphology determined the ratio, BI by BT ratio. But here B is somewhat different sort of the thing is there. Atypical RBB and atypical LBB. What we mean by typical RBB and atypical ABB? will be shown on the next slide. And whether the concordancy is a positive one or negative, what does it mean? I shall explain with the aid of the next few slides. So if those are negative, that means you are not dealing with the VT, you are dealing with the SVT. So in this way, we are dealing in this topic. We are also dealing with the mainly dealing with VT, but we are also dealing with the SVT indirectly. It is not directly. So we are dealing with both the important pathway, with VT pathway mainly and SVT pathway mainly. So these are the fundamental things which must be kept in mind so that we can explain the VT with more clarity, more vividly. The next slide. What is meant by the atypical RBB? In normal RBB, if you remember the normal RBB, that means the site of the impaction of the defect is over the left atrium. So left atrium is activated and the next is remaining silent for time wise. So it is not the sequential, it is one after the other. Normally one after the left ventricle activated, then the right ventricle activated. So in between the right ventral branch appears to be blocked. And this blockage is normally I am talking of normal. Normally there is a description of the double R wave in the V1 or V2, and this lead V6 will be reflecting the clockwise reflection. That's just the mirror-like reflection. Normally. But what happens here? Here there is no sequencer. Both the arms, both the flow towards the right ventricle and the left ventricle are taken simultaneously. That's the main difference. They are taken simultaneously. That's why this simultaneous flow across the V1 and V6 both makes a difference in the conception of the wave that looks like to be RBB, but not actually an RBB in true sense. That's why it is atypical. It is called atypical. In the V1, instead of this sort of the double peak, there are some differences. Either you see the monophagic R wave, or you may feel the left air bits here. Why is left air? Normal RBB, here you saw the double peak. In normal RBB, the first peak is smaller compared to the next peak. Just the reverse of this left air bit. But here the first peak is larger in amplitude compared to the next consecutive peak. That's why like the left rabbit here, it is named accordingly. And we may find also biphasic QR wave here. So either seeing either of the three waves may be seen in the V1 or V2, especially V1, monophagic R, left rabbit here, biphasic here, especially left rabbit here. If comes, your ears must be alert that I am dealing with most likely with the VT. But it's not the conclusive pathway even then. Sometimes, though it is claimed to be more maximum 80 to 90% suggestive of that VT, no doubt, but sometimes maybe misleading one. So in this one, V6 watts, you see the mirror image over the V6. Mirror image of the V6 means the RS ratio is less than 1. So just the reverse, R will be smaller than the S, or you may see the QS important here. So always remember the QS wave, like the Q wave is important here, and also would be important than LBB, atypical LBB. So by seeing the Q wave over the V5 or V6, especially V6, you may confirm that I am dealing with the VT, not other than that VT. So duration of the QRS complexes, if you measure from the beginning of the Q wave to the end of the S wave, it is only more than 140 milliseconds with RBB, rather more than that with the LB. I will be having discussion later on. This sort of the findings, we can say that I am dealing with the atypical LBB, which is one of the important morphological criteria of Ruggiero-Carter syndrome, number 4 criteria. It must be kept in mind as well, because keeping this, you can't understand the atypical. What does it mean atypical? In what sense it is atypical? Next is the atypical LBB. Normally, what happens in LBB? The septal wave. Normally, I'm talking on the normal, not in concern with the VT. Normal in septal wave is lost because the attack is on the septal wave as well in the case of the LBB. And here, normally in LBB, that's why the initial Q wave, either in the lead 1, AVL or V5, V6, we don't see it at all. And over the left interlateral leads like the 1 and the 1 AVL, V5, V6, we see some sort of blurring over the top. Either there's a blurred or the form the bifid as well. So this sort of the thing is seen in the case of the V6, and over the V1, V2, we see either the DPS wave with initial plus minus initial R wave plus ST elevation of the from V1 to V3. Normally I'm talking of, and with the prominent T wave. This is the picture of the normal left bundle nozzle pattern. But what happens here? The V1 pattern or V2 pattern in terms of the depth of the this S is being maintained. It is deflected. So initial R wave is always more than 0.04 second. Initial R wave is always, whether we talk of anywhere in the VT, the initial R wave is always more than 0.0 and therefore more than 40 millisecond to better associate. So this it is more than 0.04 and there is a wider sort of the QRS complex. So the entire QRS duration will be somewhat more than 160 millisecond with this sort of pattern. And although V6 part, we see the presence of the Q wave. There is no cancellation of the Q wave because the septal wave is intact here. So you can't, better to say, the septal wave is not intact, is not being inscribing this Q wave, but this Q wave is inscribed due to the muscle to muscle transmission here in the reverse manner. So the Q wave is again more than 0.40 second or 40 milliseconds. So either the R wave or the Q wave here is more than 40 millisecond due to the muscle to muscle transmission. And of course, bifid will be there. So somewhat different. So you are seeing the somewhat different sort of the configuration morphology in case with the VT in induced left bundle block. That's why it is known as the atypical left bundle block. So I think, especially, I think my PG students or the students, even they might have understood what I want to say here. Teachers and the seniors already know the fact. I know, I believe that. I am confident of that thing. What I mean by the concordancy? Normally, we make some mistakes here. Even the clinicians, including myself, used to make the mistake, no doubt. And students, if in clinicians we make the mistake, what do you think of the students there, whether PG students or the undergraduate students? What do mistake? The concordancy say that you see the complete either positive wave throughout the P1 without the trace of the positive component. In the case of positive component means in the positive QRS, the S component, even a smaller amount, would be absent. So the complete positivity from V1 to V6, V2, V3, V4, V5, 6, they indicate the positive concordancy. Otherwise, if any sort of negative wave is there, you can't think of. Sometimes we think, oh, I'm seeing the predominancy of the positive wave, so it is most likely positive one. No, never so. And just why true is with the negative one. If we are seeing the negative one throughout, from V1 to V6, it is a negative concordancy. Why do they proceed? If I say there something is coming, my exploring electrodes over the chest, something is coming from behind towards the front. That means it is coming towards the electrode, towards the exploring electrodes. So positive wave will form there. All the waves from starting from V1 to V6, they will be showing the positive waves in genesis. That's why if the site of infection is posteriorly situated over the basal part of the part, because basal part of that means it is covering all the V1 to V6, not in part of that. So the site of infection of the foci is over the postobasal part, you may see the posterior positive concordancy. That's the significance. By seeing the positive concordancy, you can also see the, it means some sort of site here. Where is the site of the VT formation? And just is true with the negative. The top bottom for the negativity. If that is seeing all the, that is covering all the V1 to V6, like the postobasal as well. Here the negative, because it is going away from the electrodes round towards the back. So it is entry position. Impacts of the foci is entirely situated apical, covering all the parts. That's why we are seeing the negative concordancy through what? From starting from V1 to V6. That is the important to say. So this is the concept, dear my colleagues, respected colleagues, and my dear friends. Is the concept of the concordancy here. Now we should know the recent criteria has been coming here. Recent criteria, what we call the muscle to muscle conduction. What we call also known as the R wave peak time. Actually, the wave of dominancy QRS is having the peak as well. So start of the peak from the Q wave, or the better say the bottom to the R wave is normally not the weight, the ventricular activation time. Ventricular activation time by definition should be less than 50 millisecond, less than 50 millisecond. If it is somewhat more, it is defective. It is said in the literature, in the books. But here the authors of this genesis have kept the three criteria. Now, one criteria, there must be a presence of structural heart disease. There is a one criteria. Either from the history of myocardial infarction or so on the past history of any disease, consider heart failure having the left ventricular ejection fraction less than 35% and device there in the with the patient, either the ICD or the CRT. Then you can say the patient is having the structural heart disease. Either of the two, either of the three, at least one, either three. If no present, that means that this criteria is zero, equivalent to the 0 1. And lead 2 and AVR. AVR is taken from the vertical plane, and lead 2 also taken the vertical plane, because these two leads are very important leads in the case of the detection or diagnosis of the VT. That's why. So thus, if for the purpose of simplicity, always we talk of the 40 milliseconds. So they are also give the 40 milliseconds as a measurement part of the R wave peak amplitudes. If the peak R amplitude is more than 40 milliseconds, this criteria is positive. If in lead 2, it is positive in lead 2. If lead 3, the AVR, it is positive in AVR. So you remember the 40 milliseconds very natural, very, very important in contrast with the you see everywhere, in contrast with everywhere, because 40 millisecond concept is very more than 40 milliseconds concept is very essential to be understood here. So if you see the more than two criteria means more than the structural criteria, lead 1 criteria, lead 2 criteria, or the APR criteria, out of these three, two criteria, or at least two criteria, or even more than that, it will be attending with the case of the VT, no doubt. Otherwise, we don't dealing with the case of VT. This is only to remember here. The remaining blue part, you just forget it. Only remember this far, more than 40 milliseconds is only. That's why you are seeing the slanting sort of the lessening limb. Here in the dam, the ascending limb is somewhat slanting towards the peak. Why? Because it is more than 40 milliseconds. That's why the ascending limb is being transmitted. This is looking like a slanted limb. If you see the slanted limb over the lead 2 and or lead AVR covering more than a small square of the paper ECG paper, you are safely say that this point is positive with this effect of the things. And this known is known the muscle to muscle conduction in the form of the R wave peak time. This is the known as the very important criteria. Nowadays it is being assumed as important criteria, because anyone, students, whether postgraduate, even the nurses, even the staffs of the coronary unit can measure it very quickly, but it's not by 100%. Every criterion is not 100% accurate. Then how to conclude, how to arrive to a conclusive part? This is important by this criteria. We have to say before that part, the see, that's just a minute, hold a minute. Just a hold, yes. A pause of the few seconds for me to correct my laptop.
Now is it okay?
Okay. It's okay? Are you hearing my voice, sir?
Yes, sir.
Yes, okay. Then I'm going further on. This is the master chart. I call it master chart in assessing VT. If you keep this printed copy of master card over the clinic table or the student by the studying table, the whole concept will be clear. I have divided concept vertical path. I have prepared this concept by my own labor of 2 or 3 days. Vertical plane on one side, horizontal plane on the other side. Vertical, I have mentioned all the four components of the criteria. You just tick whether you just simplify the ABR purpose for the purpose and see which criteria is positive. You make a tick. You may mark a tick. Either one part is, of course, you may step over the next part, but for purpose of the accuracy, you just tick mark all the components. So all positive components may be marked there. Opposing QRS and limb leads. The limb leads may show the positive waves either in the one AVR with corresponding negative waves in the inferior leads, or the reverse of that. Reverse of that means you may see the negative wave in the AVR or the AVL and one, and the positive waves over the inferior leads. So either of the two, what is known as the opposing QRS limbs criteria, this is one of the criteria taken by the, actually I have borrowed it from the limb leads algorithm. I have borrowed it from the lead algorithm system, because sometimes for the students, even for the clinicians, sometimes it may be difficult to be count the accuracy or locate the accuracy by the QRS axis determination. That's why if you seeing either of the two, You are dealing with the opposite QRS QRS carrying the limits, and you are dealing either with the north-west axis or the extreme axis deviation near about by the plus minus 30, just towards the positivity. So either of the two, if you see, it is more or less going towards the VT. The noble vessel criteria last more than 0.4, 40 millisecond, more than 40 millisecond with a more slanting towards the apex, with either with the lead 2 or the AV and so on. In the presence of the structural heart disease, all the things I have spent. So you first make the vertical plane, seeing the vertical plane over which of the criteria is I'm seeing is a positive one. Tick the mark. By tick the mark by the plane, and go to the horizontal plane as well. And all the criteria what we have discussed with the Brugada syndromes stepwise. Don't do step by you come just repeat all the criteria. Absence of the cars all okay. One RS interval is so okay. More cars complexes, then IV dissociation. I'm seeing the vision rate and so okay. Morphic criteria, they atypical IV or atypical IV, positive and positive controls like that. All you put all the things. So if you put all the things, your brain will be working sharply. Whether you are dealing with the SVT or you are dealing with the VT. Plus, you may be in doubt even then. You may be doubt even then if the doubt extends in amount, then the next time, more likelihood VT with the following consideration. If the age is more than 50, 35, usually when we were students, it was taught, but now somewhat later age is being considered 50 or 60 like that. Positive predictive value up to 85% with the age beyond 35 years. The structural heart disease, like coronary heart disease, congestive heart failure, cardiomyopathy, etc., feminist of either one or more than one, they do says that. So if you're seeing the doubtful VT morphology on ECG in the presence of this one 3-1, and you're not able to decide whether I'm dealing with the VT and SVT, it's better to treat it as a VT because it is life alarming situation. It may degenerate into the ventricular fibrillation and the patient may die. You may lose the patient. That's why these sort of things, if you remember this thing, the last slide is very also important. Here I have tried to put all the positive findings of this VT. We have understood the capture beat, what we mean by the capture fusion beat here dictated by the red horizontal line. Below is the horizontal line, the capture beat, fusion beat. Already we have explained the things there. We have spent the what is mean by the left layer rabbit sign below the ECG. We have the class, of course, is more than 140 milliseconds. What is true with the case of the RBB, typical RBB. We have considered the concept that understood the concept of Brugada sign more than 100 milliseconds. We have understood the presence of Q wave either in the VC, either with the horizontal, either with the left atypical right RBB or atypical RBB. In both it may be present. So all the things have been explained. I have explained, not explained the Joseph's criteria, but indirectly I have explained it. Joseph's criteria is the sudden turning of the wave towards the negativity. And this turning of the wave may produce some sort of jigway conduction because the conduction is not so smoothly occurring as we see in the case of SVT through the Purkinje myocyte junction is sharply descent, sharply transmission to the myocardium, endocardium to precardium, and sharply turn in the form of the T wave from endocardium to the precardium. So this different pathway, we are not seeing here this different pathway here. So the swelling of the notch or the presence of node nearby the native, either proximal to native or distal somewhat native, these reception signs set to be positive. So I have books by books criteria. I have explained with this sort of the ECG, all the criteria, all the positive findings. So the first ECG of the having the cancer master table, this ECG having this ECG, these two ECG must be kept over table or the at least over by the students, whether the PG students or the graduate students, to have the cancer, not to miss the diagnosis of the VT. That's why that's the only purpose there. So my purpose is here is only to formulate a short of the universal accepted model of the master VT diagnostic chart. Only purpose being. I may be wrong, that's a different issue, but I have tried my best. I have tried my best, which is not mentioned in any book of the ECG universally. I'm talking about global. Any book of the global sort of the thing, they have not tried to form this master chart with that of the previous existing criteria. So this may it may be a revolution in the field of the diagnostic criteria, but it needs something more. It needs the validation by the experimentally based basis. You have to see the 100 cases, 200 cases of the VT, and just the criteria, how many percentage of this thing is present here in this person, then you can validate. Then the world is going to accept it. Otherwise, the world is Dr. Ketan has talked the faltu things. It makes no difference at all. So you have to, Dr. Ajay Kumar Sinha, attest to this big institution Vedanta may do this work, because he sees the so many cases of the VT. So all the VC cases collected together with clinical history may form a big criteria to the global, sir. Big global conclusion be there. I have left my practice. I am not having access to the patients. So I am handicapped here. I'm handicapped at Ahmedabad, no doubt. But the persons, my senior persons who are not handicapped, they see that some number of cases there, they do more, form the more criteria there, the more based on masterpiece criteria there. So I may extend my help from my within heart to those persons who are interested from the master charts. So I think Dr. Ajay Kumar Sinha is a very competent cardiologist of our country, India, not only of Bihar, and he can do so. I'm fully confident. So if you do so, he is always welcome. He will be welcome by the globe, like the Gurgada or the Vargi. He will be welcome by the globe. And he made something else. He ate something else by his own study. So this is the way where some new things come to the science. But there are some misunderstanding to be cleared, to be understood in a better way, to have the foundation of the VT diagnosis. How the mechanism? I was cleared in the mechanism that in the beginning is the re-entry, tiger activity, or the enhanced atomicity. This concept must be understood very clearly so that no sort of confusion remains in the mind to make the diagnosis. Re-entry, it means the something is circulating around something. So say the central scar is there, whether it may be to the post-MI scar like that, most commonly, something will form around that. Some part of the scar may be extended somewhat more laterally or medially from the start of the endurance. So pathway is circling. When it touches that effective pathway of the scar pathway, the effective period is gone there. So cycle getting repeated again. So one thing before that discussion, all the 3 points, I should say this is the infra-bundle hisses. VT is the infra-bundle hiss site or sort of the tachycardia. So VT rises distal to the bifurcation of the His bundle, either in the specialized connective tissue, ventricular muscle, or the combination of both. Is very important one. Either combination of both. So re-entry, most common site is re-entry, scar related, most MI. Tag activity. It is very interesting. It is challenging to understood it there. Dr. Ajay Kumarji, may I know the timing you spent up till now? I'm not hearing sound, sir. Not hearing sound, sir.
Yeah, we can go for another 5 minutes and then take some
10 minutes.
questions.
I may be skilled for the 10 minutes, sir.
Okay.
Early after devotion, if you charge a bottom of the pistol, be pressing, the bullets come out in succession, tick, 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 like that. This tick tick is like the knows the ticking mechanism. This ticking mechanism is not possible by the after the during the deposition, because deposition is completely restrained process, effective refractive period, the absolute refractive period, so it can't take place there. It is only taking place over the refractive part, say over the 2-3 part, or after being recovery during the phase 4. So this early after deposition, after deposition is taking place, is known as after deposition. Early part, that means 2 or 3 parts is there, and delay is there at the end of the part phosphate. During 2 or 3 part means you are having the more sort of the plane surface there. So many bombardment possible there. So more many bombardment is the polymorphic VT, and this more likely occurs with the case of bradycardia phase. Sometimes the bradycardium element may be present. You don't know whether my heart is beating. Sometimes mostly you are ignorant, but you may be ignorant, may be well-being with the palpitation, but may not be well-being with the mild sort of the bradycardia unless you get the syncopal periods or getting like that. So more likely at slow heart rate, this broadening of platform is there with more bombarding at different places. So polymorphic BVT, if it is bombarding over the prolonged refractive period or the QT interval, it makes the form the toxicity point. This is very important to understand. Thus, the reverse is there, occurs during the phase 4 and linked to the high intracellular calcium, seen the disease toxicity, catecholamines, excess. I'm not going the details. Atomicity means instead of being stoppage of the 4 being by the sodium potassium ATPase, no, this sort of slanting, there's sort of steeping. So steeping allows the continuous flow of the current through the in the form of what we call the continuity, enhanced atomicity. These words I must sort possibly time. I'm not going to discuss more. The same thing I have explained here, so I may skip this slide as well. ECG findings classification. If three or more PCVC in a row or the more than 3 millisecond duration in duration, millisecond, less than 30 seconds duration, it is either non-sustained VT or NSVT. If it is the more than reverse of that, more than 30 seconds or causing the hemodynamic instability, may call it sustained VT. And monomorphic means only one sort of the morphology. If polymorphology, it is polymorphic VT. If it is a prolonged QT interval, if the prostate is point, just I'm running fastly to obey the command of my boss, Dr. Ajay Kumar. But head related concept is also equally important. If you deal with 100, I'm saying that you are dealing with the more than 100, but sometimes more 100, what to what extent? Up to what extent? If it is extended up to the 100 to 120 BPM, it is known as the classical slow VT. This classical slow VT indicates the pathway is more lengthy. Pathway is the slow circuit pathway, or this myocardium is there in the substrate, so the slower speed is there. That's why the heart is being limited to 100 to 120. When it occurs in the post-infarct S3 VT, dilated cardiomyopathy, sometimes post-perfusion arrhythmia also indicate, but somewhat the rate is even below 100. It may be 90, it may be 60 to 80 in the form of the accelerated idioventricular rhythm patterns seen after the perfusion of the this myocardial infarction. So here lower chance of the VT, more similar running with the atrial beat. So there's more chance of fusion beat or the this fusion or the capture beat will be more there in spite of these things. VT if more than 100, 200, maybe more than in between 150 to 100, we are tipping with typical fast morphic VT. I say few sentences about the VT more than 200 VT, fast VT, because it is fast with somewhat different VT. It is utilizing the pathway of the Purkinje system plus minus muscular pathway. Purkinje system pathway is having the quick succession, 1.5 to 4 millimeters per second, millisecond, not per second, milliseconds. So it's a fast quicking pathway. So it's more fast circuits on normal tissue may be observed there. In the case of certain vascular VT, or this on the CPVT, critical polymorphic VT, or the some other pathway as well, right? RVOT VT. So this is the importance. If you see this rate of 102, it's not narrower because more rate is there, the narrower becomes the required width. So if you see this sort, you can see in your mind that I'm dealing with this sort of the VT, which is dealing with which is concerned with the Purkinje pathway plus minus association with this muscular pathway. Just a few examples. Here the site of the impaction is nearby the posterior vesicle. So posterior vesicle is having the nearby area is having the slow pathway, and this posterior vesicle is having the fast pathway to the there in lodging of there in the Purkinje fiber. There's a combination of both. So combination with produce the excess superleaf. So it is looking like the left anti-vesicular block, looking like that, left excitation. And because the RB test later on, that's it looking like the RB blockage. So if you see this sort of the combination of the RB pattern like left excitation rising close to the left vesical vehicle, especially in young persons, either de novo without any sort of things at rest, especially in the males, or captured by the energetic stimuli, either by the physical stimuli or the emotional stress one, or by the induction of the induction by the beta glucine. The mechanism is this reintent tachycardia here. This is somewhat different. It is not the wide complex. It is near. It is neither the narrow complex nor wide. It is nearby. It is nearby. It means 120. It may be nearby 130 millisecond, 140 millisecond. Not wider. It is not wider and safe. So it's the picture of that thing. This is the RVT, is the same thing. In here, the RVT is not the QR line. It is different one. Because RVT is the side, that's why it is coming downwards near about the R plus 90, either towards the right side or towards normal range. If 90 was leftward, it means that it will be normal. Rightward is the right excitation. So it is the mechanism of that thing, and wide complex will be there, no doubt. I'm dealing with it separately. And left bundle block morphology will be there because it is taking place of the right side. So left will be there. Early transition zone is there. That is to be worried about much here this slide. Here is typical side catecholaminergic polymorphic VT, CPVT normally known. Why so? It's very there is a concept we should have the concept the threshold heart rate. Threshold height means if say it is usually at the range of the 120 to 140 normally with CPVT. If you are having the heart rate 120 to 140, your EC is okay. If you go beyond that, you may have bidirectional VT, induction of this begin, because threshold is lost there. If threshold more threshold, less threshold, that means the liberation of the critical minds from this on the myocardium issue. So it may take the form, say it is most visible over the frontal plane. Why? Because say the left frontal branch block is having left fascicle is having the site of the this thing. Here is then again going to the left side, then the right side, and the bundle like turning. So biphasic. Just fast word, sir. So concluding remark, you should have VT analysis is not about memorizing the patterns. It's not about the memorizing retro pattern. One should be acquainted with the heart's language. Please be acquainted with our Devanagari language of the Hindi with clarity, and so having lies with the confidence. The flow of electrical current through both the electric vertical main and horizontal planes must be understood well to make the VT analysis on EC truly simple and precise. What I want to carry this thing. That's why I kept this topic as a name as well. The site is the ECG man. You have to be the ECG man. Whenever you analyze the ECG, you have become the ECG man. You become the ECG man, like the war man, like the Modi man, like that. You have to be the ECG man. Then you can analyze the things very accurately. Because ECG leads all the ECG concepts, then maybe buried, or maybe in rather grafts inside the brain, the heart, both. With these words, I extend my thanks to all of you with the patience sharing. With thanks again, because I belong to Gaya originally. That's why I have kept here the Buddha, Lord before me. So excuse me if any error or omission on my part. Thanks, sir. Dr. Jagmasya, next to you, sir.
Thank you very much, sir, for a brilliant lecture. This was more of a basic science and details of the mechanism of ventricular tachycardia. Any question from anybody? Any question from anybody? You can raise your hand, or you can.
Keep on the chat box, sir. You may see the chat box and then transfer the question to me, sir.
I think, is there any question in the chat box?
No
No.
question.
I remember only one thing. My vision of treating and understanding ventricular tachycardia has been, if you see a white complex tachycardia, which is hemodynamically unstable clinically,
Okay. Yes, right, sir.
treat as VT.
Yes, sir. Fine conclusion, sir.
Except for VT with a narrow complex or a QRS which is near normal, can be, as Dr. Khetan explained, that it could be a fascicular VT. But otherwise, if you see a white complex tachycardia, this is VT unless proved otherwise. And the simplest way is, because whenever you examine a patient or see a patient with VT, things are in a very bad shape. You don't have time to analyze and go on applying the criteria and all those things. So if you see a white complex tachycardia with bad hemodynamics, this is VT, number one. If you see a white complex tachycardia which discordant axis, means a VT which is left LBVV with right axis or RBVV with left axis, this is VT, unless proved otherwise. So with this, I think I must thank Dr. Khetan for his brilliant talk, brilliant lecture. And anybody has any question, we will like to take those questions. Any question from any of our brilliant students over here? So in the end, you remember this, what Dr. Khetan told, that concentrate on AVR, white QRS, axis, try to find out the axis. If the axis is leftward and it is RBVB morphology, it is VT. If you have a left bundle morphology, right axis, this is VT. So discordance between the axis and the type of morphology will tell you the diagnosis. And because you don't have great lot of time to think about it. You hardly have any time to think about it because VT has to be managed faster. Otherwise, the person is going to die. Other thing I must convey is that even some VTs are hemodynamically stable, as Dr. Khetan was telling. So if you have if you have condition like RVOT-VT, right ventricular outlet tachycardia, VT, patients are quite stable, and many idiopathic VTs, they live for many years without dying. So that's very important. All the VTs are not having a bad prognosis. So this is one. And some VTs are, calcium channel blocker sensitive, verapamil sensitive. So that also you must remember that some VTs are verapamil sensitive, and they are mostly idiopathic ventricular tachycardia. So remember, many VTs are having causes, many VTs are having a background of ischemic heart disease, many VTs are having a background of electrolyte imbalance, and many VTs are having no cause. So idiopathic VT. So we have to differentiate between these two. And all VTs are not detrimental. Many of them live for a long time. But VT with bad hemodynamics, falling blood pressure, treat the patient as VT, nothing else. Cardiovert drug will not be so useful. Cardiovert, hemodynamically unstable white complex tachycardia, unless proved otherwise, is VT and should be cardioverted. So with this, I think I must thank Dr. D.P. Khetan for his brilliant talk, and all the students and doctors who are here who have got some take home message from his talk. So thank you all. Good night, sir.
Good night, sir.